on the rows, I have features. Think of these as things that happen to people: drugs, diseases, devices, procedures. You can have socioeconomic factors over there, your income, zip code if you want. And then rows are people. I don't call them patients. You don't become a patient unless you go to a hospital, otherwise you're a person. And then there's time. So if something happens to an individual, say a drug was given, let's put a 1, otherwise we'll put a 0. And here's the interesting thing about medicine, that in the electronic health record, you also get the negation saying no hypertension, or no fever, no pneumonia. So if you have that negation, let's put a -1. So that's the idea. And if you fill out this matrix over 5, 10, 15 years, then you can go looking for similar patients like the one in front of you when you have a question, and try to make a decision based on that. So if I asked you to guess what fraction of medical decisions on a day-to-day basis are based on randomized controlled trial gold standard evidence, what number would you pick? 5%. 30%. Okay, so we got a range, 5 to 30. Anybody want to go higher or lower? Orthopedics, 3%, correct. The number is pretty low. It's typically in the 0 to 10% range, depending on what field you're in. Even in a well-studied field like cardiology, only about 19% of the recommendations from the American Heart Association have RCT-based or gold standard evidence, or level A evidence as it's called. The rest of the time, you're basically going by expert opinion or by what your colleagues think or your best judgment. The second thing I want you to think about is, how often is this gold standard evidence even applicable when a patient walks in the door? And that number, too, is very small. It's 20% or less. And you multiply these two, even 20% times 20%, you're at 4%. So in about 90, 95% of the cases, a doctor is trying to make the best decision based on evidence that doesn't directly apply to the patient in front. And so what I'll try to convince you is that it's possible to look at the transcript of the medical records of similar people and make a better decision. So the Stanford Medicine magazine called this idea the great medical minds. So you can go data mining over there. All right, so I'll give you 2 examples. One is around answering clinical questions. So when you have a hypothesis or you have a question. And the second one is if you just have this matrix and you want to sit there and say, tell me something new. So discovering new insights. All right, so the first one, this started in about 2010. I was not involved in this study. The first author here, Jennifer Frankowitz, was tasked with having to make a decision about how to treat a 13-year-old female with systemic lupus erythematosus. And so what they ended up doing is, first they looked for evidence in the literature, asked a bunch of doctors, experts, got very conflicting opinions, and then they ended up searching the clinical database at Stanford, the warehouse. The hospital had seen 98 patients. No individual doctor had, but the hospital as a whole had seen 98 patients. And then the outcome they were worried about was thrombosis. And a 13-year-old female menstruating, you don't want to be using heparin unless you're absolutely sure that there is some problem that you need to be handling. And then they started out looking at the different risk factors. So for thrombosis first, these are the exact words they used to search. Out of 98, 10 patients had this. All of the different risk factors. Here you see the different words they're using, get a bunch of counts, and then calculate the risk. And then they made a treatment decision. So when I see this, I see a bunch of variables. I see some terms and concepts that stand in for those variables, some counting, and then division. And we have this data warehouse which has lots of data accumulating over time. And so if I could create this matrix that I was describing from that data warehouse, I can then find my similar patients. I can first find the terms and concepts, group them into variables, and then by examining the variables and their values in the similar patients, I can get my counts and ask a new question. Everybody with me so far? So that's exactly what we did. We did a new one. We looked at kids with juvenile idiopathic arthritis and their risk for having uveitis. The current protocols of care say that these kids have to be screened every 6 months by an ophthalmologist. And parents take them once, twice, thrice, and then if the kid's fine, nobody shows up after that. There's 4 known risk factors, the ones that I've listed up here. Oligoarticular onset, anti-nuclear antibodies, RF factor is actually protective, and a history of psoriasis increases your risk. These 4 already known. We reproduce these 4 just to convince ourselves that when we do data mining on this matrix, we're not getting some random stuff. And then we asked a new question, which a parent of a patient had, asking the treating physician that do allergies predispose to uveitis? And we asked that question, and the answer is yes. Now I can go the science route after this and try to figure out the mechanism as to why this is the case and what's the underlying immunological mechanism and so on, and that'll take me a decade to figure out. Or I can go down the practice of medicine and say, this is a question we ask every doctor visit. Every time you go to the doctor, you're asked, do you have allergies and are you taking allergy meds? If they say yes, open up a calendar and schedule an eye appointment. So the intervention is called calendaring and doesn't require FDA approval. And you could potentially prevent a kid from going blind. So this is an example of practice-based evidence of the association of uveitis and allergies that you can actually use to change behavior or change the action you might take. So I'll skip over this slide in the interest of time. This is the underlying text processing pipeline. CLEVR stands for Clinical Event Recognizer, by which we process the textual documents and got the counts that correspond to the different words like this in the electronic medical record. So I'll skip over this slide because I'll get a lot of questions. And I'll give you another example instead. So peripheral artery disease. It's like having a leg attack. The arteries in your feet below your abdominal aorta develop clots. You start walking, your muscles want more blood, it doesn't arrive. It's like having a heart attack, but in your leg muscles. And the main symptom is severe pain, which is called claudication. There is one drug, Cilostazol, which has only one FDA-approved indication, which is this thing, peripheral artery disease. It's a generic now, been on the market for about 2 decades. The prescription rates for this drug is at 6%. And it has a black box warning saying it's contraindicated in people with heart failure of any severity. If you dig deeper, it has that black box warning because another drug of the same type called milrinone in a clinical trial in 1991 caused sudden cardiac death when used to treat heart failure. So this thing also inherited that label. And so people are scared to use it. So my clinician friends here who collaborated with me, Nick Leeper in particular, they think this is not as bad as it seems. But you can't get IRB approval to study a drug where the label says don't give to people with heart failure. So we went to that patient feature matrix. We found our peripheral artery disease patients. We had about 11,000, but this is Stanford. About a third of, about the remainder of these 5,700 did not come here for more than 3 or 4 visits, so we didn't have long-term follow-up. But these are the ones on which we had long-term follow-up. So we find a patient with peripheral artery disease who's given Cilostazol, so that's the timeline that you're looking at. Median time to prescription is 22 days after being seen here. And then we look at other people who have peripheral artery disease. Just go 22 days out just for being very precise. And we make a cut in the patient record at that time. So then we have the before side and we have the after side. Then on the before side, we look at all of these different features and say who is similar to who. And we can make a patient similarity matrix, which you can then visualize as a graph or a heat map or whatever is your favorite mode. So the red squares are the patients who got Cilostazol. The blue are the ones who were equally sick but got something else. And we do paired sampling. So you pick a red and a blue node close to each other. So they're very similar to each other based on all of these different things, the drugs, diseases, procedures, what were done to them. But one got Cilostazol and the other didn't. And then you go ask in the outcome side, what happened. How many of them got an amputation? How many of them ended up with a heart attack, and so on? And turns out that we don't see any increased association with any of these bad events. And I stress the word association because this is data mining. We then made a graph of these drugs, disease, procedures, devices. The colors remain the same. Green are drugs, pink is diseases, orange is devices, blue is procedures, so that follows in the same graph as well. And we draw a line between two nodes if a patient has both of those things happen to them simultaneously. And it turns out that this pink and green dot, which is Cilostazol and congestive heart failure, were connected. And they shouldn't be because the drug is contraindicated. And we drilled down a bit and we found 43 people who had heart failure and were given this drug, and nothing bad happened to them. We actually went across the street to Palo Alto Medical Foundation. They had 93 people with heart failure, peripheral artery disease, given Cilostazol, nothing bad happened. That's practice-based evidence. It's insufficient to say that the drug is absolutely safe. But if you happen to be similar to these approximately 130 people, you may want to consider this as a therapy. It is the only drug that actually improves walking distance if you have this condition. And in the data, we see that the rate at which claudication, the main symptom, flips to no claudication is threefold higher in those who get the drug versus those who don't. So it's not that we just don't have enough data to see anything. We see the effect of the drug, but we don't see the side effects. So we found no difference in major adverse cardiovascular events. That's what the MACE stands for. And we uncovered a practice pattern that clinicians speculated about, and we can put some numbers to that. So we generalized this idea into a notion of a green button. Just like you have all of these info buttons and so in your EHR, if you have this thing, which we call a green button, then when faced with a clinical situation, if you have an evidence-based guideline, by all means go use that. If not, use this approach to build a cohort of similar people, and if you have a large enough cohort that is reliable enough, and I'll get into what I mean by that, then use practice-based evidence. Otherwise, keep doing what you are going to do. Ethically, no problem with this. You would be using all the data at your disposal to make the best decision for your patient. And as a side effect, you would create a priority list of what are the clinical situations for which there is no evidence, which you can then queue up for either further trials or point-of-care randomization or whatever your favorite means of mechanism for studying them. So if there was a green button, and if you happen to press it, the description of your patient would get passed to this system. The desired outcome, in this case, we're talking about a 55-year-old female of Vietnamese heritage with asthma, and there's moderate hypertension, and we want to get blood pressure down to 90 millimeters of mercury. And what is the best antihypertensive drug to use? A common question, happens many times. What I want to see is time to event, given the cohort, how many months or years does it take to get the blood pressure under control? What is the strongest associated feature? And most important, what are the characteristics of the cohort? Is it large enough for me to trust? You don't have to follow this blindly. You can change the cohort a little bit here and there and see how stable your estimate is. And if it's jumping all over the place, then you don't trust it. So we wrote this up in Health Affairs as a policy piece saying this is what we should use electronic health records for to generate practice-based evidence. All right, so that's the part about answering a particular clinical question. And then I'll give you a little bit of a teaser on generating insights from the data. So that same patient feature matrix, so we process all of these unstructured documents. Of course, we use the structured data. Rows are patients, columns are features, the third axis is time. And then we'll start asking for this very simple pattern. How many people who have rheumatoid arthritis, then were given Vioxx, and then got their first heart attack? Okay, I'm only looking for first diagnosis of arthritis, first prescription of Vioxx, first occurrence of a heart attack. You can make up all of the other patterns. that you took Vioxx, nothing happened, or the arthritis was after, and so on. And then you can put them in this 2x2 table. And there is a parenthesis around this. You only get in if you have arthritis. And then you can make a plot. So the x-axis is calendar time. The y-axis over here is the strength of the association, which this red line is tracking between rofecoxib and a heart attack. The dotted lines are the error bars. The y-axis here is the number of people on whom this observation is based. The green line is tracking the exposure, which is the A and B cells, how many people who were exposed to this rofecoxib thing. 2005, that line goes flat, so that's good. That's when the drug was recalled from the market. No new exposures after that. But in 2003 is when this lower bound of this confidence interval was above 1. That's when, if I had this data mining thing running, I would have picked up the phone and called someone saying, hey, I see a problem here. In hindsight, everybody who's tried to look at this has found the Vioxx signal. It was so strong. But in our case, we could call out 6 out of 9 recalls in the past decade just by using data from one institution. All right, I'll skip over off-label use in the interest of time. Actually, I have 1 more minute. Let's try this. So drugs have FDA-approved indications, but doctors can prescribe them for whatever the heck they want if they believe it will truly work. So about 20% prescriptions in the US are off-label. And a lot of it is just scientific experimentation guided by understanding of the physiology. So Avastin blocks the growth of blood vessels used for solid tumor treatment in cancers. And someone thought that maybe it'll block the growth of blood vessels and can be used for treating macular degeneration. And it actually works. So that's the classic off-label use example. So if you want to learn this from the data, I want to look at this matrix and I just want to learn that this drug and this disease, that pair is off-label use. So how might I do that? So we built a list of about 9,000 positive drug indication pairs and about 35,000 negative drug indication pairs. So think emails, spam and not spam. So I have a drug disease pair that I know the drug is treating the disease, and I have a drug disease pair that is something else. It's not a treatment, it's just something else. And then we go through the clinical documents, we go through public data sources and create features. So characteristics about a drug disease pair. How often do these get mentioned together? If they're mentioned together, what comes first? What is the distance in time between their mentions and so on? 25 such characteristics. And then we split this set into training and test. We learn a classifier. So think of it as something that tells you whether an email is spam or not spam. So in this case, it's telling whether a drug is treating a disease or not treating a disease. And then we test it. Yes, it works. You see all 9s mostly over there. So whenever this classifier says a drug is treating a disease, it is right about 95% of the time. Take that classifier, go to all possible drug disease pairs, apply that, make a bunch of predictions, sort them by confidence, remove things that appear like common sense or known uses. And then at the end of the day, we end up with 407 uses of drugs that we've learned straight from the data. Drug A treating disease B, which is not in any medical textbook or in any drug knowledge base, but given the distribution of its mentions and the association with the diseases, we think it's being used to treat that disease. And then we can sort them based on the risk of the drug and the cost of the drug. And the ones that are high cost drugs and very dangerous drugs, well, we better make sure that they're actually working. All right, so I'll end with sort of this visual again, that we have this data structure. You can build it from 1 hospital, 5 hospitals, 10 hospitals, the whole country if you get lucky. It does happen in non-US locations like UK and Denmark. And then from this, we can essentially learn what I call the graph of medicine. What happens together and when? The probability of cough given fever and probability of pharyngitis given fever and cough. You can learn this directly from the data. You don't have to guess anymore. Is it more likely, unlikely, or less likely? And so we actually did this for all drugs, disease, procedures, and devices, and are going to publish this graph so that other people doing such computation can benefit. It's going to come out in Nature Scientific Data under the same title, Building the Graph of Medicine. So with that, I'll end. I hope I've convinced you that you can use data in a clinical data warehouse to generate practice-based evidence. I showed you a couple of examples in pediatrics and cardiovascular medicine, drug safety, and just learning new uses of drugs. I'll stop there. Of course, it's not just me. It's 13 other people in my group doing this. Mm-hmm. Yes. We have a prediction. We have experimental evidence of how that drug might increase the risk of heart attacks. And we have a study underway with a few collaborators in Denmark to see if that association stands in other databases. And yes, so we have a prediction. I don't know whether it's right, so we'll find out in a few months. Yeah. So the general response is pretty positive. And there's actually many groups doing this. You might have heard of an institution called PCORI, Patient-Centered Outcomes Research Institute. How many of you have not heard of PCORI? It's the only institute in the United States with the mandate of trying to assess the comparative effectiveness of therapies for questions that matter to patients. It has that in its founding mission. And they're funding something called PCORnet, which is a network of 11 clinical centers and 18 patient groups in order to form a distributed network of patient data so that you can answer these kinds of questions. So that's one. There's 3 other networks like this. Most of them focus right now on administrative data, so billing and claims data. What I showed you was also looking at the unstructured documents. And if you talk to clinicians, about 80% of the valuable information is in the unstructured documents. So in terms of the response of others, this is something that a lot of people appreciate is necessary. And nationwide, it has already started. I mean, of course, when you do a big project, it'll be small steps. But in 2-3 years, this should be something that a lot of people are talking about. Yeah. So I would want to put it in the hands of patients and doctors. So research is nice and great. There's 300 academic medical centers, but there's 6,000 hospitals. So for real impact, it has to go to the hospitals. Yeah. Absolutely. So there's a study out of UCSF that shows that the degree to which you feel connected in your neighborhood is a stronger predictor of cardiovascular mortality than blood pressure. Now, how the hell am I going to even get the degree of connectedness you feel in your neighborhood in that matrix? So yes, a lot of information is outside of the electronic medical record. And this approach can only answer a certain set of questions. In order to be very comprehensive, you have to look between the blind spots of the health system, which is things that happen outside of the hospital. And there's probably 50 startups in this area that are trying to connect the dots between 2 doctor visits. So I'm pretty optimistic that in a year or 2, if the establishment doesn't move, somebody else will figure this out and make sure how to collect information about things that happen in between. I think I'll stop here in the interest of time, and we can chat afterwards.